Now it's my task and pleasure to talk about something impossible, the bloodless cardiac surgery. Is it just a promise, or is it reality? And where, if it's reality, where is the limits? Of course, we have talked a lot and heard a lot about fantastic things, about how things can be done very nicely, quick, without any loss of bloods, without any scars. And of course, we know that we cannot achieve that, but we work on that. We use smaller cuts. We work also on perioperative maneuvers like fast-track concepts to minimize ventilator support and also hospital stay, because that's where we want to go. Our cardiologists don't need an ICU. It's just we. And of course, we want to do this without blood. And this for all patients of all age groups. This is vision and mission. But how can we do that? Because we need cardiopulmonary bypass in almost all corrective surgery. And this bypass, as you can see, has a lot of tubes, reservoirs, and that have to be filled with something, with blood or with water. Otherwise, it will not work. And this is a typical example of an adult cardiopulmonary bypass machine. And you can see the prime volume is about 1.5 liters. So if you, and our perfusionists do that all the time, calculate what the expected hematocrit on bypass will be. It's a simple formula, including the hematocrit of the patient, the blood volume of the patient, and the prime. And this is an example for an adult cardiac case with 40 hematocrit and 6 liters of blood volume. And you can see that it's very easy that if you start with a hematocrit of 40, it comes down to 32, which makes a hemoglobin of around 10, which is perfectly fine for the whole bypass. But our patients are much smaller, and the blood volume of our patients is about infant 300 mils. And it's very easy for you to see 300 mils included in this formula. You will come down to something around 6.7 hematocrit, which is an HB of 2. And it's very obvious that this will not work. Not for us, but maybe for an ice fish. This is possible. This ice fish has a hemoglobin of 1 and lives in very cold water, close to the Antarctic seas. And of course, you cannot have a hematocrit of 45, because this would not flow. So basically what he has is very little hemoglobin and the oxygen that is transported just by solution, physical solution. We are no ice fish, so we need higher hematocrit. So we need to get this heart and lung machine smaller. And this guy I want to introduce to you is our chief perfusionist. We call him the master of mini. Has over 25 years of experience now, and is also very active in writing papers. And his main topic is, of course, blood-free cardiopulmonary bypass. And when I started this job here 1.5 years ago, there was a big arguing, despite he was showing me that with his bypass machine they were able to operate on even smaller kids, even on premature babies. I was not convinced and said, why should we do this? And he said, well, it's patient's wish. And of course, if you ask the patient's parents what the problem is, they will always ask you, do we need blood? And if you can say, well, maybe not, they are much more happy, as long as it's safe. And he also told me, oh, this is simplify the whole method, because what he does by priming the heart and lung machine is just filling in water, and that's it. And of course, you know, there's transfusion-associated problems, which I don't want to talk about. So we went into this process of change management, and I pulled out this article. This is published by Richard Jonas from the Boston group at that time. And it says clearly hemollution is dangerous. You know, it is associated with adverse outcome, perioperative, and in diminished neurodevelopmental capabilities of these infants, if you look at it. And he said, well, yes, but did you have a close look at it? I said, yes, of course, it's a single-center, prospective, randomized trial, and 150 patients, 5 years, corrective, easy, simple, and complex. And they made 2 groups, hematocrit 20 and 30 at start of the bypass and during low flow. And then they increased it after rewarming to the normal level. So after the surgery, the hematocrit was similar. But he said they all cool to 18 degrees and have low flow, and 1/3 had circulatory arrest. So Leo said, well. And he said, well, look at that. It is also published over the first 24 hours after surgery. They had a lower cardiac output, despite they had similar hematocrits. So, do you think that's similar groups? I said, don't know. And in fact, this guy was right, because 5 years afterwards, the same group, Boston group, published this study. They evaluated the effect of hematocrit by slowly increasing it on outcome parameters. And they found from hematocrit of 24 and above, there was no differences in cardiac function nor in neuro or mental development indexes. And to even prove this study, they made another group, one group 25 and 35, and had also neurodevelopmental examination and brain MR after 1 year and found no differences. So I said, well, I agree. So let's try it, but the transfusion trigger should be at 8 gram per deciliter at the pump, and then that's fine with me. And so he was happy, and I was questionable still. I was not really sure that everything will be fine, but all the data that were available at that time said there's no danger. So the story was that after May, I think, of last year, we didn't use any blood prime anymore. This is how we run our bypass, pretty much standard, high flow, mild hypothermia. We use regional perfusion if we do the arch repair or Norwood circulation, Norwood operation. We use no MUF, because this would increase priming volume. And we use, during the bypass, tranexamic acid. And this is, I think, very important, and I didn't have that before, and the experience, and I really like this, tissue oxygenation monitoring. This is what we need, what we use, this Hamamatsu monitoring. And what we can see is the tissue oxygenation measured by optodes of the right and left side of the head and the right leg, left leg. So it gives you very much like very good information of the oxygenation, the perfusion at any stage of the operation. I know that there's people who say, well, you can basically measure anything, but during operation, they will exactly tell you, Achim, there's something wrong with the leg. There's something wrong. Did you clamp it right? Because it is an immediate drop. If the cannula is not sitting right, it's kinked or something, there's immediate, will tell you there's a venous congestion. You should check your cannula. So it gives you a lot of information, which is really very, very helpful. And of course, you need small pumps. They must be freely movable. The reservoir is very close to the patient. It's the same level, of the table to make these tubes small. And that's why we need support, because we don't have the downhill drive. We need vacuum-assisted drainage, which is very low, I think 10 to 20 millimeters of mercury. That's enough, we don't need more. And small oxygenators, small tubes. And because as you can see, the level of the volume in the reservoir is very small, you need a very awake technician. There's difficulties, of course. Yeah, there's limited vision into the operative field, very limited tolerance for tube kinking, and of course there's almost no comfort for the second assistant, which led to us to do the operations just by two, which works, which I didn't think. And this is the priming of our usual heart and lung machine now in the neonate, and you can see you come down from 1.5 liter to 90 mils. So it's 1/3 of the blood volume, and that means that hemodilution is almost minimal. And that's what we need. This graph shows you, displays you the kilogram of body weight. And what you see that at a weight of 3 kilograms, you basically need only a hemoglobin of 11 to reach more than 8 grams per deciliter on bypass. So we can basically from 3 kilograms upwards, we can offer any patients the blood-free operation on bypass, as long as the HB level is above 11. So to our results, this is our patients which had been operated on pump, that were smaller, 15 kilograms. All above we didn't look at, because I think that's standard in all big centers, that there's no blood priming above 15 kilograms body weight. 31, only 31 at that stage didn't need any transfusion until the end of the hospital stay. 118, so half of it needed transfusion during bypass because the trigger was undergone. And also after surgery, after operation, on ICU, 100 were transfused. Most of them because of low cardiac output signs, and of course there's much too much lever too much less indication, because triggers of 8 for repairs or 15 for palliations were met. This is our special care for our Jehovah's Witnesses. What we do is to elevate to high normal hemoglobin levels, using iron and erythropoietin, and that's basically it. There's not much further what we do. And this is the last 3 infants we operated on, from 2.9 to around 5 kilograms. And you can see that the trigger point of 8 has never been reached. And they went all to ICU with an HB of 10. And this is what I wanted, you know. There's no reason to get in danger with the patient. They should be very safe. So what are the patients looked like in our last year who did not need blood or needed blood? Basically, they had a little higher hemoglobin, and of course they were heavier, at least 3 kilograms heavier, had a shorter bypass and clamp times, and of course had shorter ventilation and ICU stays. So what it says, when you don't want to have blood transfused, you have to have a higher HB level, and in the more complex cases, difficult postoperative courses, you will have the higher chance to get a blood transfused. Oops, wrong way. Safety is a big issue in Germany, as as everywhere in the world right nowadays, I think. So we do, as all the big centers, we do our quality analysis by sending all data to the EICTS database, which gives you a clear view of where you are. This is our results in the last year of our infants with a mortality about 2%, and compared to the mean mortality in the EICTS database, which is 160,000 operations, more than 45 centers all over the world. So I think we compare well. So I can conclude that blood-free priming and bypass is possible and safe. I think bloodless hospital stay is still something which we cannot achieve in the majority of patients which are lighter than 15 kilograms. This is really difficult. What we have to do is, I think, to think of further strategies, especially on the post-op curves. I think there's no much more to win, and by just decreasing the priming volume, this is perfectly done, and there's not much more to do. But we can do what we can do is preserve ventricular function. So in these patients, we go very liberal, leave the chest open for 1 or 2 days, just to overcome the first 24, 48 hours. And we have to reduce the blood drawing by, I think, using continuous central venous oxygenation and end-tidal CO2. This is the last slide, and I wanted to thank you for your attention. And Nelson Mandela said once, it always seems impossible until it's done. And I think who could know better than he? Thank you very much for your attention.